Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We're talking all about osteoarthritis today, and joining me to talk about this is board-certified rheumatologist Dr. Robert Goodman with the Arthritis and Rheumatology Clinic. Thanks for joining us.
Glad to be here, Courtney.
Absolutely. So, we're talking about osteoarthritis, and this is a topic, or we talked about it in our midday news. This is something that's pretty common in our U.S. population.
That's right. Osteoarthritis is probably the most common type of arthritis. It is a wear and tear type of arthritis where, Courtney, between our bones, if you had bone rubbing against bone, you would have a lot of friction. So between the bones, we have a cartilage, which is a tissue that has less friction. If you were a mechanical engineer from Louisiana Tech, you would say, we want to cut down on friction in the joints, and you would put a slippery material in there, and that slippery material between the bones would be cartilage. Osteoarthritis is when that cartilage gets wear and tear, and it's sort of like an asphalt highway that has potholes in it or cracks in it, and that's what's going on a tissue level with osteoarthritis.
Okay, yeah, thanks for sharing that. And so with Healthline, we like to receive calls from you guys, but we're going to wait just a little bit, about 10 minutes in, and we're going to answer some calls from you guys. We'll have that number on our screen in just a little bit, but I'm going to keep asking some of my questions, so be sure and jot down any questions that you have and give Dr. Goodman a call so that we can hear from you guys. So we are talking about osteoarthritis, so that cartilage, so that sounds like something that builds up over time, right?
Well, osteoarthritis is sort of a gradual wear and tear type of arthritis. Rheumatoid arthritis and psoriatic arthritis, a person can go from feeling fine to having pretty significant rheumatoid arthritis in a few months. Osteoarthritis is something that might gradually develop over years, and it might be that somebody might have had an injury playing football in high school football, and then years later, decades later, they have osteoarthritis in that injured knee where maybe they had a torn meniscus decades ago. Another way to develop osteoarthritis, if somebody does repetitive work, maybe small repetitive work with the small joints of their hands, and especially if they had an inherited tendency for their parents to have osteoarthritis, they may get hard knots on their hands that would be osteoarthritis. In fact, when you see those knotty hands with bony nodularity, especially on the joints out by the fingertips, out by the nails, that probably is osteoarthritis. It also may occur where the base of the thumb connects to the wrist bone, and so the thumb has been 4-on-1 with the other 4 digits, and a lot of times as we've been grasping items, as we've been holding items, and doing small mechanical work with our hands, we can gradually get osteoarthritis when we get in our 50s and our 60s.
Gotcha. And when you mentioned the knots, my grandmother, I remember seeing that on her hands, and she was an avid cook, in the kitchen, always using her hands. You feel like that probably was something that
is a contributing factor, and it tends to be inherited, and women get osteoarthritis a little bit more than men. Us guys tend to get osteoarthritis in our weight-bearing joints, like our knees, our hips sometimes, especially if we've had some trauma earlier in life, maybe fallen out of a deer stand, or been riding, doing rodeo, or playing football, or sliding into second base when we're 19, and we get osteoarthritis later on in life. You can also get it in the neck and in the back, and in those joints, the cartilage is a single piece called a disc, and so you can get osteoarthritis in the low back, and that is a subset of osteoarthritis that is sometimes called degenerative disc disease, and that could pinch nerves as those discs become deformed and they squeeze on their next door neighbor, which is the starting point of the nerve that goes to our legs. That would be the sciatic nerve, or if they get degenerative disc disease in the neck or the cervical spine, it can squeeze on the nerves that are the starting point of the nerves that go to our fingers and cause a pinched nerve in the neck, can be a subset of osteoarthritis that is called degenerative disc disease of the cervical spine. A pinched nerve in the low back is a subset of osteoarthritis called degenerative disc disease in the lumbar spine.
Gotcha. Okay, and so we talked a little bit about, you mentioned it's genetic or it tends to be inherited.
It tends to be, but if you looked at x-rays of individuals in our 50s and 60s and 70s, you will find that about half of us will have bone spurs, half of us will have narrowed joint spaces where that cartilage has worn away. And so you can find it even, it's almost ubiquitous in the human condition, but the people that mention the symptoms, it's about 50 million people.
Oh, wow. Yeah. Okay. So inherited may be something that you get with age, and then maybe trauma that you experienced when you were younger.
Probably a combination of all of the above. And if we tend to be heavier, we tend to put more stress on the weight-bearing joints like our knees, our hips, and our low back. And so that tends to increase the risk of getting osteoarthritis in those sites. And then people that have diabetes, whether it's sometimes because the type 2 diabetics might be heavier, but also it tends to occur in diabetes in general. And there's an uncommon condition in which people have too much iron in their body called hemochromatosis, and that can cause the cartilage to be more fragile, and they can develop osteoarthritis in a bit more accelerated way. So there's several ways to get osteoarthritis: trauma, wear and tear, inheritance, and some of these metabolic conditions.
Interesting. Yeah. So many different things. So, so some of those symptoms that are associated, would you say that there's pain associated in those joints?
Yes. And sometimes a rheumatologist can distinguish: is this pain osteoarthritis? Is this other pain rheumatoid arthritis or psoriatic arthritis? I wish there was a law that said you could only get one type of arthritis.
Right.
But since osteoarthritis may show up in 50% of us as we get in our 60s, you could have osteoarthritis developing gradually over decades and then have the onset of a second type of arthritis that might be rheumatoid arthritis or one of these other diseases as well.
Okay, gotcha. And so I imagine that these symptoms, if they're bad enough, it can impact someone's life. So how do we alleviate some of those symptoms?
Well, these symptoms, so some of the things that the patient can do themselves can be to get to an ideal body weight, although that's can be very difficult, and we would need a nice dietitian to be pursuing that. We could eat a low inflammatory diet, and a low inflammatory diet can help in three different ways. One, it could help you lose weight, putting less stress on the osteoarthritic joints that are the weight-bearing joints. Secondly, it can make the community of bacteria in our gut that is called the microbiome look less threatening and cause less inflammatory markers. And the third way is, and we are understanding that our fat cells, when they are a bit larger than they should be, will secrete chemicals that doctors call pro-inflammatory cytokines. And these are chemicals where the fat cell is telling an immunologic cell called a macrophage, cause more inflammation. These chemicals are called toll-like receptors, T-O-L-L, like receptors that are part of our more primitive, our innate immunity. And toll-like receptors have been discovered in insects, but they are also in human beings, and they're part of our first immunity, our innate immunity that we're born with. And so the fat cells can stimulate some cells that are in the innate immunity called macrophages to cause more inflammation. So getting to an ideal body weight will help relieve the physical stress on the joint. It will allow the fat cells to secrete less of these toll-like receptors that stimulates the immune system. And thirdly, and I know we had a segment with you on pasta earlier
Right.
with you and Nate, but unfortunately, some of those starches and sugars tend to cause the community of bacteria in our gut to be a bit more inflammatory. So pasta is good, but
Maybe in
it can play
moderation.
in moderation. So.
Yes. Okay. Yeah, and it is National Pasta Day, but maybe enjoy that in moderation.
In moderation.
Yeah, good tips there. So, are there any complications that can result because someone has osteoarthritis?
Well, a lot of the complications is that you can have a harder and harder time getting out of a chair, or going up a stair, or getting in or out of a car, and that could be with osteoarthritis of your knee or hip. You might have a harder time standing for a prolonged period of time, where you maybe normally can be standing at a party with other people, or standing doing your job as a reporter, and where you can easily stand 15 or 20 minutes and do your job as a reporter, but then gradually you notice, gee, when I'm standing for a bit longer, I have back pain, and some of that back pain is radiating down my leg, and so that can be a complication of osteoarthritis. It tends to be worse at the end of a busy day and worse with activity. Rheumatoid arthritis may get better with activity. You might be worse with rheumatoid arthritis. First thing in the morning, you feel real stiff, and then when you've been active, you can kind of limber up and loosen up later on in the morning.
Yeah, okay. And so we've talked about osteoarthritis, rheumatoid, and psoriatic. So how do you distinguish between the two when you're diagnosing specifically osteoarthritis?
Well, sometimes it can be
between the three. Sorry.
Between the three. Sometimes it can be difficult because all three of those types of arthritis can cause inflammation in the joints of the hands. Sometimes lab tests can be very helpful. The lab test in rheumatoid arthritis can be a clue, because there are two lab tests. One is called the rheumatoid factor, and the other one is called the CCP test, that are helpful. They're not perfect, but they're helpful. In psoriatic arthritis, the inflammation might be in a little bit different distribution from osteoarthritis, and the person might say, oh, I go to the dermatologist, I have quite a bit of psoriasis in my scalp, and the dermatologist is using treatment A, B, or C. So a lot of times identifying, do you have rheumatoid arthritis, do you have osteoarthritis, do you have psoriatic arthritis, or a less common disease, do you have arthritis in your hands that's due to lupus, does require a bit of that medical detective work. But there are ways to tell the difference. Osteoarthritis, worse with activity, worse at the end of the day. Rheumatoid, lupus, and psoriatic would be worse in the morning and kind of get better when you limber them up. Then lupus and psoriatic arthritis, you would have those clues. Hey, this person has a rash that is worse when I'm out in the sunlight, and worse when they're out in the sunlight, and that might be suggestive of lupus. Or another person has a rash that gets better when they're out in the sunlight, and that might be typical of psoriatic arthritis. And there are a myriad of other features that help distinguish between those four types of arthritis. And indeed, there's 100 types of arthritis. And so rheumatologists are the specialists that tends to be the ones that ferret out, is it osteoarthritis or is it some of those other diseases? Because osteoarthritis is so ubiquitous, so it's so common, a lot of times the primary care doctor would be treating it, and if a person needs a knee replacement or if a person needs a surgery on their osteoarthritis or degenerative disc in their back or neck, they might be going from the primary care doctor to the orthopedic surgeon. But sometimes if there's a question, could there be rheumatoid, psoriatic, or lupus, then the rheumatologist would often be coming on board with the healthcare team.
All right, yes, thanks for explaining that. So we've got our phone lines open right now, and you have that phone number right there on your screen. If you're just joining us and we are talking, if you don't know who we're talking to, this is Dr. Robert Goodman, board certified rheumatologist, and we'd love to hear from you if you have a specific question for him. We are talking about osteoarthritis. That number is 318-219-4569, and be sure and call us and we'll answer your questions. I won't, but he will. Well, so osteoarthritis symptoms, they can be managed, but can the damage done be reversed?
We don't have a pill that reverses the damage. I wish we did. That may be in the future, but we don't have a pill that reverses the damage. We have some medicines that can help with the pain. The first medicines that might be used might be over-the-counter medicines that our viewers can get simply by going to the drugstore on their own. Some of those can be as simple as Tylenol. They can also be topical anti-inflammatories like Voltaren gel or Bengay or Icy Hot, or one of my favorites to say, because it's fun to say, is Two Old Goats, which is a topical anti-inflammatory.
Cool.
Then there are oral anti-inflammatories that can be obtained without a prescription, and those are aspirin itself is an oral anti-inflammatory. Ibuprofen, marketed under the name of Motrin most of the time, or Advil, and Aleve, which is the marketed name, but it is naproxen sodium as well. So those are three non-steroidal anti-inflammatories, and Courtney, they work on the same mechanism of action as a primitive medicine person would say, in primitive societies would say, chew willow bark to relieve your inflammation, and N-acetyl salicylate, which is the active ingredient in aspirin, is in willow bark.
Gotcha.
So those would be ways to treat osteoarthritis orally. And then rheumatologists and other doctors have a variety of other non-steroidals that are prescription only, but many of them, almost all of them now, are generic, so they usually are going to be about $4 for most people's on most people's insurance plan. If a specific joint is having particular problems, then rheumatologists, orthopedic surgeons, or pain management doctors might do injections into the joint. Some of those injections can be steroid injections or corticosteroid injections, which is injecting a powerful steroid anti-inflammatory as opposed to taking an oral non-steroid. And the steroid anti-inflammatory might be injected right into the knee, or right into the shoulder, or right into the hip joint as well to relieve the pain. In the past 20 years or so, hyaluronic acid has been developed to be injected in the joints. Hyaluronic acid, or HA injections. A good source of hyaluronic acid turned out to be from the coxcomb of a rooster. And so you can purify hyaluronic acid from the coxcomb of a rooster, which is a form of collagen.
Okay.
And hyaluronic acid can then be purified, put in an injection into the joint that used to be called, and some of the names were Synvisc and Suparts, but the nicknames for that hyaluronic acid injection would be the rooster shot.
Oh, I love it.
And so corticosteroid shots into a joint, or the rooster shot, hyaluronic acid injections into the joints, are done by rheumatologists and orthopedic surgeons. However, if none of those medications, unfortunately, will restore the cartilage. None of those medications will take the bone spurs away and restore that 70-year-old joint as if you were 25. With osteoarthritis, we oftentimes have to refer patients to our orthopedic surgery colleagues, and this is probably the most common reason that orthopedic surgeons do total joint replacements, if they were doing a total joint replacement of the knee or the hip or the thumb bone to treat or relieve osteoarthritis. The orthopedic surgeons who specialize in spine surgery, or the neurosurgeons who specialize in spine surgery, might be doing actually working on the subset of osteoarthritis that is also known as degenerative disc disease, to relieve if the deformities, the bone spurs, or if the deformities of the disc, those discs are bulging against a starting point of the sciatic nerve, or if that disc material has ruptured and be said to herniate and squeeze the sciatic nerve. The Latin term for squeezing or narrowing is stenosis. So a complication of osteoarthritis in the neck or back could be spinal stenosis, and that would be a pinched nerve that would be relieved by a neurosurgeon or an orthopedic surgeon. So osteoarthritis is, we rheumatologists have to be humble because we don't have as good a treatment for it as we do, say, for rheumatoid arthritis or for psoriatic arthritis or some of the other diseases you and I have talked about. And so we are oftentimes handing those patients off to our orthopedic surgery colleagues.
Right. Spinal stenosis, is that the one when you can think of when you're using the grocery cart in the grocery store, kind of leaning over to take that pressure off? Is that something
exactly.
that you typically...
And so spinal stenosis, the Latin term stenos means narrowing. And so if your cardiologist says you have stenosis of a coronary artery, it means you have atherosclerotic plaque that puts you at a risk for a heart attack. But if a back surgeon, a rheumatologist, if a musculoskeletal doctor, maybe a musculoskeletal radiologist, is using the term spinal stenosis, then they might be talking about the openings, the nerve windows. In Latin, window is foramina. The nerve window or neural foramina in the cervical or lumbar spine might be being pinched and might need the assistance of maybe a pain management doctor to inject around that nerve window or that nerve opening and inject some joints that are called the facet joints that can cause the pinched nerve, or inject around that bulging or that herniated disc. And if that doesn't work, a lot of times the rheumatologist might be handing them off to pain management. Pain management might say, gee, we've tried several things, but we need to have a spine surgeon operate on that pinched nerve.
Yes, okay, and getting back to osteoarthritis, so what about therapy measures? I'm assuming like physical therapy, is this something that can at least prevent it from getting worse, or any other types of therapy that can help?
That's right. Physical therapy is extremely important. And if we're talking about osteoarthritis, the lumbar spine, if we can strengthen our core, strengthen our abdominal muscles, strengthen our muscles around our lumbar spine, and strengthen our core, and have our physical therapy colleagues help us strengthen that core, then we can take the stress off of those facet joints, the stress off of those discs, and help osteoarthritis of the lumbar spine, osteoarthritis of the cervical spine, but especially the lumbar spine. The physical therapist also will come into play, especially when a person has had that total knee replacement, that total hip replacement, and to rehabilitate after those types of surgeries. And
does bone density at all play a role in osteoarthritis?
Bone density doesn't play as much a role in osteoarthritis. It certainly is central to osteoporosis, but it doesn't play quite as much of a role in osteoarthritis.
Okay. Yeah, just curious, because that's another common problem for older adults as well. So
exactly.
Yes, and you always stress the importance of self-care. So if someone does have osteoarthritis and they are taking the precautionary measures, taking the anti-inflammatory medications, what are other maybe self-care regimens that they can?
Well, some of those other self-care regimens, as we've already alluded to earlier, is get down to that ideal body weight, and so that we put less physical stress on our joints. And also we're getting down to that ideal body weight so our fat cells, our adipocytes, adipose cells or adipocytes, are sending less inflammatory measures to our immunologic cells. And thirdly, we're trying to make the microbiome look less threatening, as far as with a good healthy diet. Bracing can be helpful, and so if somebody has a bit of osteoarthritis in their right knee and they enjoy doing running or Pilates or yoga classes, sometimes bracing can be helpful on one knee or the other. And back braces are very important as far as if somebody is engaged in a career or a job where they do some heavy lifting, or if you're a weekend warrior and you tend to get osteoarthritis your back. and I know that from personal
Yes.
use, that putting on a back brace can be very helpful. And,
Yeah.
and it's sort of using the brace to strengthen our core and take a little bit of the power,
Pressure,
the
yeah.
pressure off the
Yes,
lumbar spine.
those are some excellent tips. And so if you are just joining us, Dr. Robert Goodman, he's here in the studio with us. He's a board certified rheumatologist whose office is right here in Shreveport, the Arthritis and Rheumatology Clinic. And I know that you have an important announcement that you'd like to make for our viewers, and I'll give you a couple of minutes to explain that.
Well, thank you, Courtney.
Yeah.
I've sent out letters to my patients, and I wanted the viewers to know that I will be retiring December 31st of this year. It has been my honor to take care of patients in the Architects and also work with you and the others at Channel 3. So I will still do Healthline, of course, today and in November and December, but those will be my final Healthline reports with you guys.
Oh, and you have such a wealth of knowledge, of course, in the field of rheumatology, and I always enjoy your Latin explanations and going back to where everything came from. You just have so much to offer this area, and you will definitely be missed.
Well, thank you.
Yes, yes, I will definitely miss having these conversations with you, but we'll enjoy them for the next 2 months for sure. So, well, with that being said, December 31st, so that's just a little over 2 months away. Will you be accepting new patients at this time?
Well, if I wasn't certain if I was going to do that, but I found that there are some patients who want me to see their family member, and some primary care doctors would say, within the caveat that I won't be able to see them beyond that, that I am doing consults with the knowledge that we would be doing a true rheumatology consult, sending that report to the primary care doctor, maybe have a brief follow-up in a few weeks, and hopefully to be able to get them some needed treatment. If they need further rheumatology care, depending on the disease, if it's a disease that the primary care doctor is used to treating, like it's a patient with gout or a patient with osteoarthritis, and we get them on a good treatment regimen, and the primary care doctor is comfortable with just carrying on with that treatment, then they may choose to do so. If it is a treatment like a complex rheumatic disease, like rheumatoid arthritis or lupus or psoriatic arthritis, we might be able to get them on a good starting point, and then that primary care doctor might hand you off to another rheumatologist as we go forward in time. But it is bittersweet. I've enjoyed the trust of patients in the Architects, and I sincerely appreciate your trust, and it has been a very fulfilling career for me.
I love that. And how long have you been practicing?
Almost 40 years.
Wow, that's incredible. That's awesome. I mean, what a legacy that you're leaving. So,
Courtney, I was cleaning out my office, and I came across a notebook. And it was a notebook I was doing a little bit of bench research when I was a rheumatology fellow, and it was 40 years ago, and it was at the basement of the VA hospital in Memphis, Tennessee. I did my rheumatology fellowship in Memphis before coming back to Shreveport. And there were my notes from 40 years ago, and they were dated August the 17th of 1984, and it had an approach where I was my job was to go around the VA hospital in Memphis and go see a patient that had rheumatoid arthritis or lupus or psoriatic arthritis and draw blood from them, and I was growing their lymphocytes and stimulating them with a protein called interleukin-2. Interleukin-2 is a communicating protein number 2 that was between white blood cells. And so, to paraphrase Barbara Mandrell, if Barbara Mandrell was country when country wasn't cool, I was dealing with immunology and interleukins when interleukins weren't cool.
I love that. That's so cool. I love that. And we're so appreciative to have you in our community, and best of luck to you. Enjoy retirement.
Well, thanks. And I'll be back the next couple of months.
Oh yeah, we'll have you back. But Really exciting and definitely bittersweet, but thanks for joining us, and we'll be back to do it again next month, so stay tuned, and thanks for joining us today.